Welcome to this session. So this is an open session. It's one of the mentoring sessions. So it's not part of the core modules for the course 3, the introductory course. So this is a session that's open to all. Today, the format of today's session will be that we have one longer presentation, and then we'll have time for questions, comments, and discussion after the first presentation. So just a few points about Zoom as usual. So if you're having problems with your connection, if you can please try turning your video off as a first thing, because we know that usually improves the connection if you turn your video off. Also, if we can just ask you to keep your audio on mute unless you're asking a question, just so we don't get any background noise during the presentation.
You're muted, Catherine.
Yep.
Thanks, Gillian. So we want you to share your questions and comments as you go along, and please do write them in the chat box. So you can write them in English or you can write them in Bangla. And we have our faculty who will be having a look at the chat box as we go through. And after the presentation, we'll share some of those comments and questions. Please also feel free to hold on to your question and ask it yourself at the end. We're very happy to have an interactive session. We want you to speak, we want you to be engaged. Please do share. And we also want to hear about your experiences of delivering community palliative care or caring for patients in the community as well after the presentation. So I will introduce today's speaker. So today we have Dr. Tasnim, who will be speaking to us about community palliative care and how it works. Sorry, before I introduce you further, Tasnim, I just want to ask, actually, we have a couple of faculty members who are new this time that weren't here in our first session last week. So I just want to ask Marianne, if you can introduce yourself first before I introduce Tasnim. If you want to unmute yourself.
I'm Marianne Phillips. I'm in Western Australia, Perth, Western Australia, and I'm a paediatric palliative care physician and an oncologist. Previously worked in Africa, Romania, Cambodia, and Vietnam.
That's super. Thank you, Marianne, and welcome to these sessions. And I just want to ask Gillian as well, if you can introduce yourself, because I know you weren't with us last week. Gillian was in the faculty for the last courses, but she wasn't here for the first session last week. So go ahead, Gillian.
Thanks, Catherine. Hi, everybody. I'm Gillian. I'm a palliative care physician in Western Canada and a director with the Two Worlds Cancer Collaboration and director of the India program. Hi, everybody.
Hi, Gillian. Thank you for that. So back to today's presentation. So as I was saying, Dr. Tasnim is going to be the presenter today, and she will speak to us about community palliative care. So Tasnim was the project manager for a community palliative care project within the refugee camps and was working previously with IOM. So Tasnim has experience of setting up community palliative care services in the areas where you are, most of you are working. So without further ado, I'll welcome Tasnim. And are you going to share your screen, Tasnim, or would you like Saeed to do that?
Thanks, Catherine. Saeed will do that.
Okay, thank you.
The slides, yeah. Thanks, Saeed. Welcome, everyone. We will talk about community-based palliative care. I am Tasnim Azad. I'm a Bangladeshi medical doctor. I worked as a program manager for IOM Palliative Care Program in Cox's Bazar Rohingya response. Next slide, please. I often get questioned from many of you that palliative care is a very new concept, and you people felt interested to work in palliative care. Just to let all of us know that history of palliative care is like we are having clusters around the Western world, and is mostly related to 19th and 20th century. The modern palliative care movement is started actually in 19th and 20th century. And if you consider the care for dying, people who are dying, is not that new. It's already in our tradition, or it's already in human civilization. And last but not the least, the continuity of century-old tradition is actually the palliative care. Next. And it's good to know that many international organizations and bodies are already considered palliative care as an essential component of healthcare. You can see I have collected some information, and when they started is like Canadian Senate in 2000, year 2000, and European Committee of Ministers in 2003. You can see Worldwide Palliative Care Alliances and IAHPC, International Narcotic Control Board, all of them already acknowledged that palliative care is a part of essential component for healthcare. And the very last one here I wrote in 2015, the UN Sustainable Development Goal Roadmap. According to that, palliative care is component for universal health coverage. I am sure many of you can remember in the last class we talked about universal health coverage and how it can affect how it can affect the continuity of promotion, prevention, cure, and rehabilitation. So palliative care is also part of that. Next. Next slide, please. Yeah. The slide looks like time machine. I will take you back to 1843. You can see it's written here. This is the first institution who was caring for the dying people. It was in the France. And second line is about in 1885, first home for dying was opened in Britain. In now, what we could say, it started in France in 1843, and close to 40 years later in 1885, we could see in Britain also they had home for dying people. Next one. These photographs are pretty old. You can see Our Lady Hospice in Dublin. It was established in 1879, and the St. Joseph Hospice in London. I am sure many of you have heard this name, is in 1905. Next. And regarding the evolution of palliative care, you can see a photograph of Dame Cicely Saunders. Is according to the palliative care and palliative medicine, it should be appropriate, scientifically based, and patient-centered treatment. And you can see first demonstrated in St. Joseph Hospice, and later it was in St. Christopher's Hospice. And after that, establishment of recognized specialty in palliative care in Australia, 1987, New Zealand, and UK. Next, please. This is the photograph of Dr. Elizabeth Kubler-Ross, who interviewed 500 people who were dying, and it's called On Death and Dying. She had concept for better home care for cancer patients, and she honored patients' choice when it comes to their healthcare. Often we say that to show the respect to a patient, is really important to know what he or she is willing to get from you for her treatment purpose or for her end of life care purpose. Next, please. This is Belfort Mount. We recognize him as a father of palliative care in North America. And he opened a unit in Royal Victoria Hospital that's called the Palliative Care Unit. It was in September 1973. Next, please. I talked about the western part. I talked about Australia, New Zealand, and you can see it's written here a replicable model for LMICs. That means low and middle income countries. And we have taken example from our neighborhood country, India. The first hospice in Mumbai, in India, it was in 1986. And in 1999, the NNPC took some initiative that's called Neighborhood Network in Palliative Care. And very first one is related to our today's topic, community mobilization and ownership. Second one, they took initiative for involvement of the local government on it. And thirdly, it's like incorporation of palliative care or integration of palliative care in primary healthcare system. Next, please. Very common question, how we provide palliative care. And from palliative care definition, we talked about many aspects like the medical knowledge, we talked about psychosocial care, we talked about spiritual care, and it should be interlinked with the religious views, the way they are maintaining it. The culture is really important. And there are some ritualistic values. It depends from culture to culture, from places to places, it depends. So it should be kind of blended with our updated medical knowledge if we want to provide someone end-of-life care. And the slides I have shown before, my question towards you is it new? No, it's not new, because the concept of care, if you want to care for dying people, it is already started when the human civilization started. It's still continuing. None of us could say that, no, we don't care for people who are dying. We do. That's how we started. And the palliative care also have an agenda with this to care for death and dying. Next, please. We often say, what does it mean in public health, how the palliative care idea works? And in public health, we have to consider some other issues. It's written here, health service challenges. What are the challenges available in the health service that you are providing? Is like recognizing the limit to service provisions. The service you will provide, definitely we have some limits, some challenges. Patienthood versus citizenship. How do we define that? When as a patient I'm visiting you, you can take my history, you can give me proper treatment, you can set a follow-up visit for me. That's the patienthood, the time and the way I'm taking service from you. And citizenship, I can give example from my country. As a Bangladeshi citizen, what's available as a citizen to get the healthcare services from my country? As a citizen, what I will get. You can see health services versus social capital. What are the services available in our facilities that we provide to the patients? And social capitals means what's the understanding of values, the rituals, the norms in my own place. Family versus community. What are the services available from my family to a patient who is suffering from death or dying or incurable diseases? And what's the view from our community towards that? Palliative care holism versus public health holism. Holism means it's like understanding a thing as a whole, not some of its parts. So if we consider palliative care as a very new concept, then we won't be able to understand the holism in palliative care. And in public health, where does it stand? The very last one you could see, working on versus working with communities. If I pick the example of Rohingya community, we could say, let's work on palliative care in the Rohingya camp. Or we can say, let's working with the Rohingya community about palliative care, and decision is on you, how you will integrate this palliative care approach in this public health field. Next, please. Again, continuation of public health palliative care. Definitely we will ask what is necessary. The very first one I wrote here, prevention. And good example could be, I will give example of HIV/AIDS cases. Like we know how to prevent this. Even if a family person is suffering, what are the necessary steps that we should take to protect others? Then second one is harm reduction. As I work in the Rohingya camp, I saw many myths, many wrong practices there. And our approach could be to make a reduction on that self-harm or the harm by the community or by the family. And third one is definitely early intervention to understand what's going on here, how to identify the problem and how to work on relieve all this. And we can work on this through these methods. You can see in the right side, definitely the community development. Our community should know what's going on and how we can prevent or how we can minimize the risks, how we can have a better plan for early intervention, early implementation. Second one I wrote here, public education for health promotion. Third one could be really challenging in the Rohingya camp is like ecological or setting change, because many of our patients, they were staying in uphill in a very, very difficult geographical locations. It is difficult for them to visit us, even for community visits. It was difficult for our people to go there. And you can see civic policy development, definitely national guidelines and other things related to this. And services redesign is like, once you designed one model, you can think about it later and you can make some changes. I will come to in the next slides, I will come about this. Next, please.
I'm really sorry that most of the
It's okay.
due to the bandwidth problem have been connected.
Do you want me to share now, or you can do that?
Are you? Can you see the screen?
Yeah. This one is done. Please go to the next slide.
Okay, sure.
Yes, I have taken an example from UK initiatives, what UK have done for their palliative care activities. You could see they did some introduction of community development and public education initiatives. They had compassionate communities. It's like the community, those who are willing to help in palliative, those who are willing to do volunteering, those who are willing to do some activities in palliative care services. And many of them have had experience from their family member died with cancer or some other diseases, and they themselves, they made a community, neighborhoods and cities. They named it as a compassionate communities, and they do have their own charter also. And school and workplaces, they have end of life care and grief policies already. And it's like community sector support. They move toward community sector supports away from the palliative care based or controlled volunteers. Next, please. We often say culture and context is important. You can see here in my slide is written that research-based is like the community participation has a greater emphasis on importance of context. If you don't consider the context, you will definitely not understand the community and the community participation properly. And participation is really important, but without the social context, you can't define it at all. Next. Next. Said, I think we have missed one slide. Next. Now we will talk about community palliative care. It's like many of our patients who need palliative care, they sometimes they are fatigued, they are unable to move from one place to another. They are having already some challenging symptoms, which is not getting well with available treatments. And it's causing them to, it's like they are unable to go for a follow-up visit or for a to visit a clinic physically, and it's simply not possible for them. For these reasons, it's like healthcare workers like us, we provide palliative care during home visits. We offer home visits. That's called the community palliative care. Patient will not come to you, you will go to the patient. And in next slides, I will discuss about how we provided this community palliative care, even how you can think about better community palliative care. Next, please. As we say, community palliative care, we should consider it depends on what? Definitely it depends on the local context, in which place you are working, and you have to understand it well, the context here in this, even I can take example of the Rohingya community inside the Cox's Bazar, Ukhi and Teknaf region. Second one is, what are the resources available here? To provide these palliative care services, what you have at the moment. And third one is mission's priorities. The mission, the vision and mission with what you are working in palliative care, what are your priorities to work on this? Next, please. We often get questioned that if we have to visit patient's house, who will go to visit this patient? It could be the community health worker, the nurse, the medical assistant, physiotherapist, even the doctors. It actually depends on the need basis. Actually, according to the patient condition, we can decide who will go for this home visit or for this community visit. Next, please. As I said, we will think about community care, even the home visits. How do we get benefits? I mean, our patients, how do they get benefits from this community care? I could say many advantages, but during the last days of life, not only in Bangladesh context, but also in Rohingya camp, the patient himself and his family wants him to be staying at home rather than staying in inpatient unit of one of our hospital or healthcare centers. So it's like it allows the patient to stay with the family without traveling to and from the hospitals. And family member can be trained on how to provide the basic nursing care at home. And even for managing symptoms also, we can train them. It could be like which medications should be taken as needed, which one is you can prefer not regularly, or some special instruction about medication and care of this patient. Second one could be community palliative care can reach more patients. And how do we do that? It's like inpatient beds are limited. Sometimes it's expensive, but I want to mention in Rohingya camp, it was free of cost. But if you consider the bedded hospitals inside the Rohingya camp, it was I think it's still low. So you don't have to occupy one bed for this patient who is dying. You can observe some common methods. You can teach the family caregiver, and often you can make one schedule to visit the patient with your team whenever needed. And it needs little infrastructure. You don't need hospital equipments and other thing to do that. And the symptom control and assessment, you can manage it at home. And to provide home care settings, it will increase the community awareness. I can give really good example. While we started visiting patients inside the Rohingya camp, we got response from the other households. It was like, if it's not treatable, but still you can do something for this patient, then let's do it for us also. And I'm sure one of my nurses present here, we got one patient, he refused us that I have been taking treatment for several years and not getting cure, so I'm not interested to get any service from others. But while we were visiting neighboring places, he came by himself and expressed his interest, because his understanding was, if someone is coming to my place and if I don't have to go to the far places or to the hospital admission, another thing, definitely I would love to take this. Next, please. How to develop or implement a community-based team is nothing written on a stone, because the way we started, it was like we were still learning how to do that, and definitely it requires trust and acceptability. And definitely you will not get it within a day. Trust and acceptability takes time. And the places where I worked in Rohingya camp, yes, it took time to get that trust from their side. And we tried to engage the community and community leaders. It's called Maji. Some of the mosques there was imam and mullahs. We tried to talk with them to understand the local dynamics and power structures. It's like whom we should talk and who can understand that why is needed inside this community. One thing to remember, that the priority as a healthcare team, what we have set in our mind, or what we discussed in our office or in our healthcare center, might not be same with the community priorities that the community is looking at us. So it could be different. So our work would be to listen to this and be flexible to respond to the needs of the community. It's like not having something hard and fast, no, we can do that. It's always like understanding and listening to them, and then keeping yourself in a very flexible situation. I will talk about stepwise approach, how to set up a community service provider, community palliative care provide service inside the camp. How we did that as a member of Fasiuddin Khan Research Foundation. How we developed these community palliative care services for forcibly displaced Myanmar nationals. In short, what do you say, FDMNs in Bangladesh? Next. Next. Slide next, please. In this stepwise approach, we started with sensitization of local community to the problems of patient with incurable disease. The patient who is suffering from incurable diseases, we tried to talk to the community, local community, and we invited all groups and organizations who involved in social and healthcare services providing in that area. And we did some meetings with them, that who we are, what we want to do, and what will be our next steps. And we shared what are the possible ways to help these patients and the community. In some cases, those who are bedridden, having incurable diseases. And we did training for healthcare providers also. I say it as a sensitization of healthcare workers. And from today's lecture also, I have touched that point, why it is important, even it's not new, how we care for people who are dying. We trained CHWs on basic nursing care, some communication skills, how to provide emotional supports. And we gave them some tasks like to identify what are the problems for bedridden and terminally ill patients in their neighborhood. We tried for weekly review meetings and to discuss about this solution, even the existing resource, how we can help them from this, and we documented all this. We tried to link them with other organizations who are providing social support. It could be like Food for Families, who are in need of educational support for their children. It could be example of someone having incurable disease and having 3 children. He has no idea how to send them for informal schools inside the Rohingya camps. Next, please. We trained nurses and doctors in palliative care, initiate a nurse-led home care program under the supervision of this palliative care program, IOM palliative care program, established culture and good documentation and case reviews. We provided medical supports to the nurses by training of the project doctors, including safe prescribing of medication for symptom control. Even we did many trainings on what are the good alternatives for some symptoms if you don't have the first line one, how you can combine with others. And when we made sure that the home care service is established, there will be always need of regular outpatient clinic, and trained doctors and nurse definitely is the very prerequisite for you. And it was taken from the clinic in MSF facilities. The slide is taken from that part. It's like the outpatient clinic could be inside the MSF facilities. And once you establish that type of palliative care program who is visiting door to door or to the patient's home, there should be regular review, evaluation, and definitely self-question where the improvement is needed, or redesigning this project, what will work better on this. Next, please. Another question is how frequently we will go for home visit. It depends on caseload and geography. It could be once in every 1 or 2 weeks. The aim would be to anticipate the problems, to solve these problems and try to prevent them. And while we will go for follow-up, we will try to do the symptom control. We will provide support to the patient and his caregiver, the family person. And newly identified problems, what we are getting new, what we can't solve from our side, we can talk to our supervisor that what could be done for this patient from now onwards. As I said, capacity building and knowledge on when to visit, because for every case is different. You can't define it you can't define it like it should be 1 week, once in a week, it should be twice in a week. It depends on the knowledge and capacity building. And definitely the person who will visit, or the team, those who will visit the patient from door to door or during the home visit, they should know how can we support the caregiver. Second thing I wrote here, in terms of end of life care patient, it should be daily visit. I mean, the frequency should be more. And supportive meeting among the team, emotional supports toward the patient and his family. Next, please. Whenever we send one of our staff to the home visits, it's written here that what we can consider, what should be with that field visit person or a home visit person or a home visit team, is definitely the transport to the patient's home, because in campsite it was difficult to get regular transport, but somehow in a very few cases it was available to go there by walking. Definitely that home environments need to be safe. we can assess during our first visit, we can understand whether it's okay to send our staff to that home visit. And definitely the caregiver should be present during the home visit. Whenever we will take the history, if the patient is too weak, we can train the caregiver about the symptom control, how to take care for these patients, and we can address caregiver's needs, how she's coping, what she needs, what will be her next steps, and what she wants to know from our side. Availability of supervisor, nurse, and doctor to support the CHW. I said we can send the CHW, we can train the CHW, but it's not something that we will always send the CHW. There will be always good communication between the CHW and with the nurse and doctors to support them whenever needed. Inpatient facility referral need to refer the patient for disease management or symptom control. And sometimes caregiver burnout for end-of-life care while he or she is taking care of a patient who will die soon or who is dying. It's important to have our connection with the inpatient facility when we can send them for this support. We need some equipments also. It's like identification, one ID card of your staff, backpack, registration, referral, and documentation forms, a pen or pencil. In case of, Said, you were going too fast. Could you please go to the previous slide? Yes. During COVID, we consider personal protective equipment. It's like mask and gloves. And in the camp, during the rainy season, it was a challenge. I'm sure it's still a challenge to reach to the patient's home. So we consider boots, raincoats, and umbrellas to support them. Medical supplies like dressing kit, gauze, saline, Vaseline, tape, sometimes incontinence pad, urinary catheter, opioid log box, NG tube. This could be the medical supplies. And for many of our patients, we got response from patient side, even from our side also. Even our doctors suggested to provide pressure reducing mattress. It's called the air bubble mattress or foam water mattress, if available in your organization. Next, please. This is the organogram that I took from Fasiuddin Khan Research Foundation while we started working as a single provider of palliative care inside the Rohingya camp. You could see the project lead was a national palliative care consultant. Myself, I worked as a program manager, and I did not write the number of medical doctors we had. Actually, we had 2 medical doctors while we started, and upon looking at this part, I was not that happy because for this 900,000 people, we had only 2 medical doctors. And you could see here nurse, social worker, and physiotherapist we had. So the idea worked well while we implemented the BPCA, the non-clinical part of palliative care, Bangladeshi Palliative Care Assistant, and FDMN Palliative Care Assistant. They work together in a defined geographical area. When needed, they asked help from the nurse. In a very few cases, our physiotherapist visited there, and lastly, it was by the medical doctor. Even sometimes we asked for special opinion from our project lead because many of the cases were complicated. So that's how with 2 medical doctors, FDMN.
এখানে আসো, আমি শুনতেছি না যে আচ্ছা তো তুমি এদিকে আসো বাসায়
I'll just
It's
ask
like
if you can put a mute on, except for
জন্য
Tasnim.
সব
Yes, can you hear me?
We can hear you now. Thank you, Tasnim.
Yeah. Okay. So the basic idea was to combine the effort from the FDMN, the forcibly displaced Myanmar National Palliative Care Assistants, whom we trained earlier before sending them to the palliative care activities inside the camp. And often we got help from the palliative care nurse, who was also trained on palliative care services. And the medical doctor decided on the routine and follow-up visits for this home-based care. That's how we worked. Even our project lead, a national palliative care consultant, she provided supportive guidance over phone. Even when needed, she visited the patient's home with the whole team. Next, please. We often say who should provide community health care, or who will be the person who can go patient's house to visit that patient. Definitely a knowledgeable one who has idea how to work on that community care part. Definitely having understanding on basic palliative care that should include pain and symptom screening and assessment, whether even sometime it could be the pain scale also. The psychosocial and spiritual assessment to understanding what's going on in terms of the psychological and social context, basic symptom management knowledge, basic nursing care, having an idea how to communicate with them. What I will take from my program, that one I worked before, we took all the Bangladeshi and FDMN palliative care assistants from the local area, so that there will be no language barrier at all. And it could be those who are able to provide basic emotional support and bereavement support when someone dies in a family or in a community. And we tried to engage them with education session and continue the learning program, because new challenges and new problems were coming up, and we tried to cope up with the situation. We tried to understand how we can manage this, how we can redesign this one for a particular patient. And definitely we need medication support for symptom control. We try to make them understand what are the medications we will use, and we try to make them understand that in which situation they can ask for help from our medical doctor. We provided them simple printed information about how to take this medication. The intellectual level, even the language was the main barrier inside the Rohingya camp. Sometimes the pictorial forms work better than the lecture or the verbal instructions. We inform the nurse or doctors if we ask them to inform the nurse and doctors if symptoms are not well controlled, if things are deteriorating, then how to communicate with us. And often we check the equipments and supplies which we provided earlier, or what we need to bring more for this number of patients, or when we will add some other home visits inside that community or inside that camp. Next, please. Next, please. Then the next one is practical support. Is like to train the patient and caregiver about hygiene, about the basic nursing care. In terms of emotional support of a patient who is getting support from home-based care, or a person who is providing home-based care, you should know that the person you are sending having some idea about human connection. They know how to provide this compassionate care. They're really good at listening, and they have an attitude that how can I help people. We in palliative care, although it depends on culture and the place where you are, but it worked in a very good way while we are holding patient's hand. or providing some words to the distressed caregiver to cope up with the situation. This is often only appropriate if the caregiver is the same sex, because in our country it depends even not only for our country but also inside the Rohingya camp. We should balance this, like the team we are sending, we have at least one female person there, could be a female nurse or a female social health worker who can be there during the session. And we try to encourage the family, engage the patients to engage the patient in daily activities, because sometime while he or she is working for her home, it feels some relief, like it gives them some pleasure. It could be anything, it could be storytelling, listening to music, or drawing. And home visit for bereavement support after death. While we set a home-based team or home-based care for a particular patient, we try to cover that part also. Once the patient is died, there should be bereavement support provided by this team. And each and every patient's documentation was done, and the documents we had forms for that, and we already archived that part also. So what I said, using some standard form and documenting the individual patient's note. And availability is like, although we are unable to visit the patient daily basis or weekly basis, but one of our team members' phone number was shared with them, and it was assured that you can call here 24/7, and then you can reach us by mobile phone also. Next, please.
I think we may have lost Saeed again. Hopefully he'll be back in a few moments, Tasnim.
Okay. As I talked earlier about the palliative care assistants, they are actually the non-clinical part of palliative care. They are not the medical person here. And what do? They used to visit the community. And they are teaching the patient and family caregiver to provide palliative care at home. During the follow-up visits, the BPCS work with us. They used to practice exercises guided by the physiotherapist earlier. I mean, during physiotherapist's first visit, if physiotherapist already have shown some exercises for this patient, our BPCS used to repeat all these exercises with the patient. So there was a really good bonding between patient and his family with this BPCS, and also it linked with our team also. And I often get questioned that how do our BPCS as a non-clinical person, how do they identify the patients, those who need palliative care? We used one tools, I will talk about it. Next, please. This is the tools. Although I started working in palliative care with Fasuddin Khan Research Foundation, I had the same question, that how these community volunteers will be able to identify this person or the family who needs palliative care from our side. And I got this from our Naranganj palliative care project. Even in Coral Slum also, I have seen the many of our community volunteers using these non-disease specific tools. It could be used by anyone, even a doctor or nurses can use this, even non-clinical person can also use this. And for ourselves, we made it in Bangla, so it was easy to understand from our community volunteers. The scale is the tools consist 0 to 24 numbers, and tools having 8 components. I will come to these components, and according to the score, any patient who will get a score above 10 should be clinically evaluated for palliative care. So when the palliative care assistant is scoring that one, it needs to be visited by one palliative care nurse or by one palliative care doctor. So after the first visit by palliative care nurse, she can assure whether he or she needs palliative care physician's visit or not. That's how, although we got really great number of patients, and later we identified actually who are the real palliative care, who are the patients who needs palliative care mostly. And these tools is now used in Bangladesh and Kerala also. Next, please. Kerala in India. I have not included the tools here, but the components, what I said, 8 components there, and the scoring should be done with this. So it's like mobility level, the activity level of the patient, and ability to self-care, ability about eating and drinking of this patient, consciousness of this patient, pain or pain scale of this patient, other symptoms. And we kept, I could see one component included here was patient is anxious, depressed, or worried. Next, please. This is the question. While we worked as a single team in palliative care inside the Rohingya camp, what worked better? Definitely the interdisciplinary team. Even myself as a medical doctor, while I started, I thought that we need at least 20 doctors to cover all these palliative care activities. But later I understood that it should be integrated in our healthcare system. And having a bunch of medical professionals is not needed in palliative care. It should be community participation and community ownership mostly. And with the interdisciplinary team, you can bring that. We had really good connection with palliative care specialists, even in ECHO faculty members also. They helped us in many aspects while we needed specialized visits for a few of our patients. And available resources. While I started working on palliative care, I came to know that we do have palliative care national guidelines in Bangladesh, and nowhere it was available as a soft copy. So that was the resource, that how do we look at it from our national perspective, and what are the palliative care centers available in Bangladesh, even the palliative care specialty available in Bangladesh and other countries. Next, please. This slide is taken from one of my nurse, and what she said, I wrote here. It was, they got one patient who was 78 years old, and the history was she had fallen down 2 years ago, and since then she is unable to move her right side and unable to talk properly. And she never visited the healthcare facilities, as she is already elderly female, and no one was there to take care of this lady. According to her granddaughter, we took all these histories, and our physiotherapist and doctor visited, the palliative care physiotherapist and palliative care doctor visited there. They came up with a differential diagnosis, and during the very first visit, patient was really pleased. Even patient's family was also pleased that although we are not visiting someone is coming here to visit us. That was the very first impression. And later on, with our regular visits and follow-up and with physiotherapy exercises, this patient were able to crawl at least, or walking with support was possible, this patient. But I'm sure her family members were sure that nothing could be done for this patient, but later on it came up as a blessing that at least she can able to access the toilet by herself. I have forgotten in which part I was, but And the very first impression was from this patient and his family side was, although we are not visiting the healthcare facilities, the healthcare personnel are coming here to provide us service. And secondly, the patient was able to manage to access to the toilet by herself, either by crawling or by holding someone else, which was close to impossible for them to think before we started providing this care to this patient inside her home. Next, please. This is the conclusion of my lecture. And I just want to say that community-based palliative care, it will reduce the total healthcare cost. Even it will decrease the number of hospital admissions, and in outpatient settings, community-based palliative care can reduce the emergency department visits. There are certain cases in which frequent emergency visits are not needed. Even hospitalization is not a solution for this patient. And we can address this by community-based palliative care. Next, please. Any question? And thanks from my side, because we will discuss the question and answering now. Thank you.
Thank you, Tasnim. There was some very useful information in that presentation, and thank you so much for sharing your very valuable experiences of setting up the community palliative care service over there in the camps. Just to say first, there was a request from Rachel to know more about the tool that you were using to screen patients, and if you're able to share that. Does this tool have a name, Tasnim, or was it one you created? And do you have a document you can share with us either in the chat or later by email?
Yes, Captain and Rachel, thank you. Saiduzaman will share this one with you, and it is not a tools that is validated, but I found this useful while I started working with the community or the team, newly developed team who has very least idea how to work on this. So it worked better for us, and I took it from website of our palliative care project in Narayanganj, and I will share it. Thank you.
Thank you. We have another question, request in the chat to talk more about communication and breaking bad news, and also providing bereavement support. So there's a lot we can share about that, and we would like to, but I think it's probably beyond the scope of this session. Let me just see, Dr. Schimmel, can you just say, Dr. Schimmel, are you signed up for the course 3? Or have you done a course before with ECHO? We will, if you, perhaps you can just write your answer in the chat or unmute yourself, because, Dr. Schimmel, I see you now. Do you want to say? I think you're muted. We don't hear you. Perhaps it's a connection problem. So just to say, Dr. Schimmel, if you're signed up for the course 3, we will have a session on communication skills and how to break bad news. So we'll be covering that within course 3. If you're not in course 3, no problem. We'll still share with you the material for that. So we have a recorded webinar, and we have a teaching session on how to provide communication support. So please do be in touch by email if you're not in course 3, and we will make sure you get that information. So we have some questions from Janina. So thank you for this insightful presentation. So one question, how are you able to include patients' wishes into the palliative care planning, mainly when they become too unwell? And what approaches do you use to engage them in such conversations, if any, e.g. advanced care planning and preferred priorities for care? Okay, that's a really good ground, or otherwise we can ask one of our other faculty members to answer that. Tasnim, do you want to answer that one? So in terms of advanced care planning and knowing the patient's wishes, is that something that your team were doing in IOM? Were they able to get to that point, or if not, I can answer that.
Yeah,
go ahead.
Catherine, I just want to mention that from the very first lecture of palliative care, we are focusing that palliative care is something is not needed during the last day of life or during the last few weeks of life. It could be months, it could be years. So often we get some diagnosis that patient is in a incurable stage, but still patient is able to talk about his or her wish and her priorities. That could be the time we can think about the advanced care planning. Even we can have a discussion that who will be the decision maker for this patient. I mean, having one substitute decision maker before the patient is getting really, really sick. So that could be a really good alternatives, because many times we decide, even in our context, we decide that that the male person from the family will be the decision maker, but which is not working that way from patient's side. So it could be both. It could be a substitute decision maker. It could be having early discussion, and it depends from case to cases. It can be same for all cases. Thank you.
Thank you, Tasnim. Does anyone else from our faculty want to add anything to that? Gillian, are you there? Do you want to add a comment to that about how we understand patients' preferences, advanced care planning, preferred place of care? Erin, do you want to make a comment on that, Erin? I can see you've got your camera on, so go ahead. Erin, can you hear me? Do you want to add a cannot unmute? Okay. So go to the left bottom corner of your screen and hover the mouse over the left corner, and you should see a microphone button to unmute.
Okay, I think also maybe Jillian had the same problem. Now I'm unmuted. Yeah, I would say that I think in many countries, official advanced care planning probably doesn't exist. Maybe Tasnim can clarify that, but I think what can really help is having the discussions. And even if that's having informally writing on a piece of paper, the people that like the next of kin or a spouse or the eldest child in the family, if they know what a patient's wishes are, and that has been discussed and possibly even written down. Again, in many countries, it's not legally binding, but if the discussion is there, hopefully the child or whoever is responsible, once the patient is not able to make their own decision, can move forward with that. So I know that probably is where you could start with the advanced care planning.
Yeah, it's Jillian. Thanks, Erin. Yeah. The only thing I have to add to that is that sort of key to this is starting early, right? Not waiting until there's a crisis and very end of life. So starting to have these discussions as early as possible. And yeah, and what Erin said. Thanks.
Thank you both. Thank you, Erin. Thank you, Gillian. And I think when Erin mentioned that there's often not a sort of formal advanced care planning, what Erin's referring to is that there are legal documents that you can complete in some countries that are legally binding in terms of your wishes. However, even in the absence of those, we can explore, as Erin and Gillian said, we can explore what is important for a person, where they want to be when they're sicker, and know that even if there's not a document that we can use as a legal document. Tasnim, do you want to add something?
Yes, please. Thanks, Irene, for mentioning this, because while COVID started, I did in-person training with many doctors inside the Rohingya camp, doctors, nurses, and medical assistants inside the Rohingya camps. And I don't know whether Dr. Anna Vuk is present here today as a faculty or not. She gave me some resources regarding the GOC, the goals of care, and how we can implement it for our patients, even the patient, those who are suffering from COVID also. We tried to address this with all of our colleagues, those who were trained on SARI ITC palliative care training, how to take this GOC notes, goals of care notes, before the patient is getting really sick or patient needs a referral from your facility to somewhere else, to address patient's wishes, values, preferences, priorities. Thank you.
Thank you, Tasnim. And there is a comment specific to COVID. Hold on, before I go to that, Anna, do you want to add anything? I think Anna is with us today. If you want to go ahead and add anything on that, Anna. Or perhaps she's not with us. So we have a question also about community visits during the COVID pandemic, and it's a really good point. And the question is, how frequent should the visits be? And most of the camps is in strict lockdown, and it's difficult to have access to the camp during this time. And this is an absolutely valid point. And of course, it changes absolutely how you can provide community care. Is there anyone here from IOM that can share with us how they are adapting in times of COVID?
Dr. Tawhid is with us, most probably. He can explain better.
Hello, good evening. Yeah, thank you everyone, and thanks Dr. Tasnim Madam for your nice presentation. It's a long time hearing from you. So yes, and during this COVID situation, the thing is really getting tough for us to continue our regular works. But as it's discussed in this meeting, we're continuing with the personal protective equipments for our home-based care and other facilities, and the facility-based care is continuing like before. But in case of home-based care, we're facing some difficulties, but we're getting the support from IOM for these personal protective equipments and other things. So as much as possible, we're continuing our home-based care and other things. So yes, the COVID situation is hampering our service by some means, but we are trying our best to continue our service. That's it. Thank you.
Thank you, Dr. Tawhid. It's good to know that you're managing to carry on visiting patients even in these difficult times. So I guess it's taking extra precaution and continuing the service. Tasnim, do you want to add something there? You have your hand up.
Yes, thanks, Catherine. I just want to add, while the COVID started, I mean, it was not that bad inside the Rohingya camp, but all the movements and lockdown started from 28th of March last year. And at that time, we had 7 patients diagnosed with cancer, and 3 of them were getting morphine from our side. So the next day, it was like everywhere is closing down. You don't have vehicle to go to the patient's home, or literally you are not allowed to access the camp. That was the instruction. And what we did, we tried to communicate with patient, because the way we take the patient history, we have a part to write down patient's mobile phone number, even if it's not patient's own, then one family member whom we can reach. So we tried to communicate with them. I can still remember, even Dr. Tawhid can add more, because we planned with them that they will come up to a station by walking, and we will, I mean, our teammates will go up to that station by walking. So it was no vehicle available, but we reached to them, and our team made sure that they are getting the proper support from our side. And one of our patients was getting end of life care. So with that 24 hours monitoring checklist, we made it 12-hour monitoring checklist via phone. So we tried to talk to the patient's caregiver and try to understand what's going on, even tried to ensure them, although phone is not the ideal one, but we tried to cope up with over phone communication and consultation that time.
Thanks, Tasnim. And it's about creativity in palliative care. It's always about thinking on your feet and doing your best you can for the patients. So there's a question about that Erin's answered about from Nazmul about whether palliative care is only provided for people who can't leave home. And it's a good point. And we've started this series with a community palliative care presentation, which was actually planned from earlier on, some months ago. We planned to talk about community palliative care. But as Erin mentioned, that palliative care is for any patients with life-limiting illnesses. And in the camp setting, it can include patients that have had stroke or are having symptoms and difficulties because of their condition, even if it's not necessarily life-limiting. Sometimes they are incorporated and included in palliative care service. And as Erin mentioned, it can be provided in hospital sessions or outpatient clinics. It's just that we know that as patients get closer to end of life or as they get sicker, we know that mobility goes down and fatigue increases, and it becomes increasingly difficult for patients to make it to clinic, which is why we do try to offer home visits for patients requiring palliative care. I'm aware of time. There was just one question from MSF that I want to address, and that was about an MSF facility. They provide, they don't have community service. Are you, let me just see if I can find the question, sorry. Dr. Mohammed Iftkar, sorry, that's Dr. Mohammed Iftkar. So we didn't provide palliative care in the community level in the case of MSF. And how can we approach it? I'm not sure if you're in Kutupalong or Goyulmara. Perhaps you can share. But essentially, what we try to encourage is that even if you don't have community service, if you have patients that you've seen in outpatients or in hospital setting that you recognize are becoming bedbound and maybe approaching end of life and need support at home, the question is about how you can do it, even if it's what we call ad hoc or one-off visit to support these patients, sort of a special case. So I know that not everybody's organizations have the funding or capacity to do community palliative care. So a couple of options. One is think about IOM, who have community palliative care service. Can you refer to them? Can they continue follow-up? Option one. Option two would be, for this patient, can we make special exception and either follow up with community health workers and relaying back to nurse and doctor, or do one-off or a couple of home visits, especially for this patient, so you can provide continuity of care. But it's a really good question, and we know that there are limitations to the services you can provide in the camp. Does that help? Thanks, Rachel. No, I was just asking if the doctor that had the question was Dr. Mohammed Iftikar was from Goyulmara or from Kutupalong, and you probably just heard Goyulmara, Rachel, so don't worry, we've no questions. Super, thank you all so much. If there are any more burning, Kutupalong, thank you, from Kutupalong. If there are any more burning questions, do write them in the chat. Erin, you've got your hand up. Do you want to add something?
I just have a question for Dr. Tasnim. So in some situations, because my background is also in community-based care, in some countries, caregivers are able to access the outpatient clinics in certain situations for like medication. Is that something that you guys did? Because that could also give people that don't have a home-based palliative care program some flexibility. Although it's not great, it's better if a medical professional assesses the patient. Is that something that could be like the bridge if the patient is not able to make it to the clinic?
Thanks, Erin. The time while I was working with IOM, we had 4 PSCs, primary healthcare centers, where we have palliative care nurse available. And it was direct communication from their side. If someone was able to visit that facilities, the nurse can directly communicate with us, and we schedule the doctor's visit within that week, even sometime on very next day. Another alternative was during COVID response, I was able to do some in-person training for most of the healthcare providers inside the Rohingya camp, those who were working in COVID facilities or not. And that was the cream time for me to communicate with them that this is the base. Even if you want, you can even, I can still remember during my, the presentations, I gave my phone number and my medical doctors, even whole medical team's email addresses I shared with them, so that anyone can reach to us. Even we got response from different programs, even IOM supervisors and managers like that, they reached out to us with some palliative care real cases, and that's how we try to cope up with this.
Thank you. I'm aware we've run out of time pretty much. So very quickly, I'd like to ask Roshan, if you are there, if you're able to give a very couple of minutes summary of today's session in Bangla, if that's possible, Roshan.
Catherine, I can do that, I think.
Yeah.
I think Roshan's having problem unmuting.
Yeah,
Here she is now.
yeah.
Thank you.
I'm here. Sorry,
Thanks so much.
I couldn't unmute myself. So sorry. Thank you so much for inviting me. ধন্যবাদ তাসনিম আপুকে এবং সকলকে। সেশনটা আসলে আমি খুব উপভোগ করছিলাম, যে আমার খুবই ভালো লাগছিল, অনেক কিছু নতুনও শিখলাম। আজকের কন্টেন্টটা নিয়ে কথা হচ্ছিল যে কমিউনিটি বেসড প্যালিয়েটিভ কেয়ার, অর্থাৎ হসপিটালের বাইরে বাসায় গিয়ে আমরা কিভাবে কমিউনিটি প্যালিয়েটিভ কেয়ারটা দিতে পারি সেই বিষয়ে। শুরুতেই আপু খুব সুন্দর করে ইতিহাস তুলে নিয়ে এসেছিলেন প্যালিয়েটিভ কেয়ারের। আমরা আসলে যারা প্যালিয়েটিভ কেয়ারে কাজ করি অথবা প্যালিয়েটিভ কেয়ারের বাইরে শুনে থাকি যে প্যালিয়েটিভ কেয়ারটা একটু মেডিকেলের নিউ একটা ইনভেনশন বলি, কখনো বলি নিউ কনসেপ্ট, কখনো বলি যে বাংলাদেশে ইনসেপশন পিরিয়ডে আছে প্যালিয়েটিভ কেয়ার। আসলে কি তাই? প্যালিয়েটিভ কেয়ারটা আসলে জন্মের শুরু থেকেই বোধহয় ছিল, তবে সেটা হয়তো ইনফর্মালি ছিল, এখন ফর্মালি এটার একটা রূপ দাঁড়িয়েছে। আমরা ইতিহাস থেকে দেখলাম যে ওয়েস্টার্ন কান্ট্রিতে 18th বা 19th সেঞ্চুরিতে প্যালিয়েটিভ কেয়ারের রূপ নিয়েছে, এবং ডেভেলপড কান্ট্রি ইউকেতে 1965 বা 67 কথা বললেন ম্যাডাম, যে তখন আধুনিক প্যালিয়েটিভ কেয়ার ডেম সিসিলি সন্ডার্স দ্বারা প্রতিষ্ঠিত হয়েছে, এবং লোয়ার মিডল ইনকাম কান্ট্রিজ লাইক ইন্ডিয়াতে শুরু হয়েছে আমাদেরও অনেক আগে 1986 এবং 1999 কথা বলেন, যেটা নেইবারহুড নেটওয়ার্কের কথা বলেছেন। তার মানে অনেক আগে থেকে আসলে প্যালিয়েটিভ কেয়ারের শুরুটা হয়েছে, আমরা পরিচিত হচ্ছি এখন। তো এখানে আপু এরপরে আমাদেরকে শিখিয়েছিলেন যে আসলে প্যালিয়েটিভ কেয়ারটা কেন দরকার, পাবলিকের জন্য বা মানুষের জন্য কেন দরকার। এখানে 4টা কথা উনি বলেছেন, যে মানুষের কষ্টগুলো সেটা যেন না হয়, সেটা প্রতিরোধ করতে পারি, কষ্টগুলো যেন কমাতে পারি, আর্লি যেন চিহ্নিত করতে পারি, তার ফলে কি হবে মানুষজনের কোয়ালিটি অফ লাইফটা এনশিওর হবে। এবং আমরা যখন কেয়ার দেব তখন আমাদের মাথায় কয়েকটা বিষয় থাকতে হবে, যে ওই মানুষটা বা ওই কমিউনিটির কালচারটা কি, কনটেক্সট কি, সেই বিষয়গুলো আমাদের মাথায় যেন থাকে। আমরা যখন কমিউনিটির প্যালিয়েটিভ কেয়ার কেন দেই, সাফারিংস কমানোর জন্য। এখন যেই মানুষটা খুবই অসুস্থ থাকেন, হাসপাতালে যেতে পারে না, হতে পারে তার ট্রান্সপোর্টের সমস্যা, রাস্তাঘাটটা ভালো না, ফিনান্সিয়াল সমস্যা থাকতে পারে, পরিবারে হয়তো টেক কেয়ার করার মতো কেউ নাই যে নিয়ে যাবে, অথবা হসপিটালে থাকবে, সেই মানুষ হয়তো বাসায় থাকলে যত্ন নিতে পারতো, কিন্তু হসপিটালে যখন যাবে তার কাছে তার জব ছেড়ে হসপিটালে থাকতে হয়, সেটার জন্য একটা কস্ট থাকে। তো অথবা অনেক সময় থাকতে চায় না পরিবারের লোকজন, এইসব বিভিন্ন কারণেই আসলে হোম কেয়ারটা দেয়া যায়, হ্যাঁ দেয়া হয়। রোগীর ইচ্ছা, চাহিদা এবং রোগীর কন্ডিশন এবং অন্যান্য যে অসুবিধার কথা বললাম। তো এতে অনেকগুলো অসুবিধা হচ্ছে। একটা হচ্ছে রোগী তার নিজের পরিবেশে থাকতে পারছেন, কন্ট্রোলটা তার থাকছে এবং সেই পরিবেশে থাকতে পছন্দ করছেন, এবং পুরো ফোকাসটা সেই রুগীকে দেয়া যায়, তাতে রুগী এবং রুগীর পরিবার কমফোর্ট ফিল করেন, এই সুবিধাগুলো পেয়ে থাকেন ওনারা। এবং আমরা তারপরে শিখছিলাম যে আসলে কমিউনিটি প্যালিয়েটিভ কেয়ার ক্যাম্পে কিভাবে প্রতিষ্ঠিত হয়েছেন, আমি খুব সুন্দর করে শিখেছি। এখানে কয়েকটা কথা আপু বললেন যে প্যালিয়েটিভ কেয়ার আমরা যখন হোম কেয়ারে দিব তখন নির্ভর করছে আমি কতদিন পর পর দিব, সেটা হতে পারে পেশেন্টের কন্ডিশনের উপর এবং আমার ফ্যাসিলিটিস কি কি আছে, আমার মেন পাওয়ার কি পরিমাণ আছে সেটার উপরে। কখনো কখনো যারা এন্ড অফ লাইফ কেয়ারে থাকেন তার জন্য প্রতিদিনই দরকার হইতে পারে, আবার কিছু কিছু মানুষ আছে যাদেরকে ফলো আপ রুটিন একটা ফলো আপ 1 সপ্তাহ 2 সপ্তাহ অথবা মাসে একবারও দেয়া লাগতে পারে। কারণ আমরা যখন যাব হোম কেয়ারে আমাদের ট্রান্সপোর্ট ফ্যাসিলিটিস সহ অনেকগুলো হোম কেয়ার কিটস এর কথা বললেন, ডকুমেন্টেশনের কথা বললেন, একটা টিম থাকবে এবং যদি যে পেশেন্টের যে সিমটমস থাকে সেই সিমটমস রিলিফ করার জন্য, যেমন উন্ড কেয়ার যদি থাকে তাহলে ড্রেসিং মেটেরিয়ালস নিয়ে যেতে হবে, এনজিটিও, ক্যাথেটার, অর্থাৎ আমি যে পেশেন্টের কাছে যাচ্ছি বা যেই কমিউনিটির কাছে যাচ্ছি সেই ব্যাপারটা আমার পুরোপুরি প্রিপারেশন নিয়ে যেতে হবে। স্পেশালি এখন আমাদের পিপিই এর কথা বলছেন, আমার এক্সপিরিয়েন্স আছে আমরা যখন প্রথম হোম কেয়ার দিচ্ছিলাম ঢাকায় শুরু করেছিলাম, তখন আমরা যে সেন্টারে কাজ করতাম সেই সেন্টারের আশেপাশে 7 কিলোমিটারের মধ্যে হোম কেয়ার দিতাম। তখন আমরা কিন্তু প্রথমে রিক্সায় যেতাম, তারপরে একটু আমাদের সামর্থ্য বাড়লো যখন, তখন আমরা সিএনজি অ্যারেঞ্জ করলাম, তারপরে যে আরেকটু সামর্থ্য যখন বাড়লো তখন আমরা আমাদের হোম কেয়ারের জন্য আলাদা একটা গাড়ির ব্যবস্থা হয়েছে। তো এভাবে আসলে নির্ভর করছে যে আপনি কোন সময়ে কিভাবে আপনি কতটুকুন ফ্যাসিলিটিস দিতে পারবেন। তো এই জিনিসগুলো আমরা এখান থেকে শিখেছি। আরেকটা শিখেছি যে হোম কেয়ারে আসলে শুধুমাত্র যে ডাক্তার নার্স দেবেন তা না, এছাড়া বিভিন্ন থেরাপিস্টরা আছেন, কমিউনিটি মেম্বার্সরা আছেন, তাদেরকেও আমরা ইনভলভ করতে পারি, তাদেরকে এম্পাওয়ার করতে পারি, তাদের সহযোগিতা নিয়ে কমিউনিটি কেয়ারটাকে আরো সুন্দর, আরো সক্রিয় এবং সাস্টেইন করতে পারি। তো এগুলোই ছিল আমাদের এই আজকের লার্নিং। ধন্যবাদ সবাইকে। দ্যাটস অল।
That's super. Thank you, Roshan. Thank you so much. And a big thank you to Dr. Tasnim for a wonderful presentation. And thank you to all of you for your participation today. It was a really great session. And I just want to share for our next week will be a session for the participants signed up for course 3. Okay, and the session next Friday will be an introduction to palliative care. So hopefully it will help with some of the questions that have come up today about who might need palliative care, how we can deliver palliative care, etc., and the different components of palliative care. So more information on all of those things to come next week. We will share the recording of this session, and so in the WhatsApp group. So if some of you missed part of the session or you want a recap, we will share the recording of this webinar, and we will share with you also a video to watch before next Friday's session to those of you who are enrolled in course 3. Okay, a big thank you again. Have a lovely week, everybody, and we'll see those in course 3 next Friday. The rest of you will see you at the next open session. We'll share details. We'll share details about the next session with the ECHO group. Thank you, everyone. Take care. Bye now.